Hi everyone, I'm Carol Higgins coming to you live from the Baptist Health Newsroom. Pancreatic cancer is widely known as being one of the most lethal forms of cancer. In fact, it's the third leading cause of cancer deaths in the U.S., but advances in treatment and in technology in recent years are changing the way we're looking at pancreatic cancer. Survival rates are actually starting to climb. So we've got two very good experts on pancreatic cancer with us today that I'd like to welcome to the show. First, we have Dr. Horacio Asbun, who is Chief of Hepatobiliary and Pancreas Surgery at Miami Cancer Institute, and Dr. Raj Narayanan, who is Chief of Interventional Oncology for Miami Cancer Institute. Welcome to you both.
Thank you, Carol.
Thank you for having us, Carol.
Of course. Before we get into our subject too deeply, though, I'd like to remind our viewers to please send in your questions anytime during this segment. At the end, we will have a question and answer session with our experts, and we'll answer as many as we have time for. Or if you're watching this on a replay, submit your questions and we'll get them to our experts for you later. So let's start. First, let's go very basic, the pancreas. Where is it in the body and what does it do, Dr. Asbun?
Well, the pancreas is a very interesting organ. Usually the main function that everybody knows is it produces insulin. And as you know, insulin is involved in the mechanism of how to regulate the sugars that you eat, etc., and how to store them, etc. Having said that, it also has another function that not very many people knows, and it helps absorption of food. And that's what's called exocrine function, meaning it produces a variety of enzymes that allow food to be absorbed into our own body. The location of the pancreas is a little bit of an issue, because it's posterior and it's very hidden. Therefore, it's not like a breast that you can easily examine, or when there's a problem, it's much more readily detected. And it's surrounded by a variety of organs. That makes diagnosis and as well as treatment a little bit more complex.
So that is a complicating factor. What are some of the symptoms that someone might experience that would lead them to wonder if they might have pancreatic cancer?
Well, every time we talk about symptoms of pancreatic cancer, we scare people. And our goal today is not to scare them. And the reason why I say that is because the symptoms are non-specific.
Gotcha.
Right, like, and I'm going to again make the analogy to breast. Breast lesion, it's palpable, or you can do screening. The pancreas has non-specific symptoms. And many times a tumor can grow and don't give any specific symptom until it's advanced. But the typical symptoms for pancreatic cancer is all of a sudden you become jaundice. If you haven't had any prior symptoms, you start to become itchy. That's jaundice, means yellow color of your skin because the bilirubin does not empty into the intestine. That is very characteristic. Other less characteristic symptoms are abdominal pain. One that's important to watch is weight loss that's unexplained. Those type of things one should watch. But more than anything, rather than being worried about if you have a bellyache because you ate a Thanksgiving turkey, do I have pancreatic cancer? I think the most important thing is to really try to follow a healthy type of living and do your regular controls.
That sounds like good advice. About how many people, Dr. Narayanan, are we expecting to encounter pancreatic cancer?
Well, according to recent statistics, it's about 50,000 new patients a year. And the reason pancreatic cancer has such a bad reputation is it's a silent disease. And most of the times, by the time it's diagnosed, the disease has or probably already spread out of the pancreas, or even if it's confined in the pancreas, it poses a challenge to surgeons because it surrounds the blood vessels in that area.
So the location, as you were saying, makes it difficult to diagnose. Does that mean more people are diagnosed when it's in a later stage?
Yes. Most people are diagnosed when it's what we call as a stage 3 or 4. Mm-hmm. And yes, that is the situation.
When we talk about treating pancreatic cancer, at Miami Cancer Institute, I know we talk about a multidisciplinary approach, and that is having experts from a lot of different aspects of cancer treatment come together to discuss cases and I know you're a surgeon, you work in interventional oncology. We have people who do radiation oncology, medical oncology, which is chemotherapy. Can you explain a little bit about what these tumor boards or meetings are and how they work to give people the best opportunity for a good treatment?
Yes, I mean, basically, if you are going to have a dedicated group of physicians that are dealing with pancreatic cancer or pancreatic diseases, you no longer can make a difference between, oh, he's a radiologist or he's an interventional oncologist. We are pancreas dedicated physicians.
Gotcha.
And as a team, we offer the patients usually multiple opinions. In the past, the surgeon was the one that usually made the decision if the patient goes to surgery or not. That's totally obsolete. And even though my pride is affected by that, I'm actually very happy because I realize that interacting with colleagues that are world-renowned and have the experience that they have as in Miami Cancer Institute, I'm able to offer to my patient the best decision possible. And this is not an advertising, this is reality. Many times we see things from our own specialty point of view, and we wear some glasses that let us see that in that way. Then the fact that I have Dr. Narayanan or the oncologist or the radiation oncologist in which we are all going to give our opinion and force ourselves to make a unified decision as a recommendation to the patient. It really gives the patient the opportunity to have a second, a third, a fourth, a fifth opinion right there on a single setup.
I think one of the word cancer obviously sends chills down anybody's spine. Pancreatic cancer even worse. But the one thing most patients and their families are desperate for immediately after the diagnosis is information and access. So now you start looking, you're doing all the work on the internet and trying to figure out. When you have an institution like ours where you have all the specialists together in one room discussing your case and all of us being objective about it, which is what happens in our tumor board, we give the patient the best chance and give them a very fair opinion as to what would help them the most. So I think that is a great thing to offer to cancer patients.
And it's all under one roof as far as you're talking about everybody coming together. And is this something that happens regularly or is it just occasionally?
Happens every week.
Every week. So that is an ongoing thing that you're dedicated to there. Is this something that's common among cancer centers?
It's becoming kind of the standard in most cancer institutes.
Okay. Let's talk about specialties just a minute. I'd like to return to Dr. Asbun, the surgeon, about how many people with pancreatic cancer are eligible for surgery.
Well, if you have asked me that question only 3 or 4 or 5 years ago, I would tell you a very extreme minority. In fact, statistics are under 10%. Having said that, that has radically changed in the last few years. And in a way is great because now more patients are getting to definitive treatments that are going to give them a chance of cure, and that's surgery. Without surgery, you really don't have a chance for cure. Then the fact that we're seeing many more patients that are able to go to surgery, it helps, but also at the same time has made the surgeries more complex because prior to surgery, we usually do what is called neoadjuvant therapy. That means prior to the surgical procedure, we give some type of therapy. And that type of therapy can be radiation. And as you know, we have a fantastic group of radiation oncologists as well as radiation modalities under one roof. It could be chemotherapy. Again, we have a group of expert oncologists that dedicate themselves only to pancreas. And the types of chemotherapy have changed significantly over the last 5 to 7 years, as well as procedures as what Dr. Narayanan does that allow us to reduce the tumor, to use a word, sterilize the edges around the tumor that are maybe neighboring vessels, and that gives us the opportunity to go in and take them out. That, along with the fact that in surgery now we apply minimally invasive approaches that I don't want to dwell into it because of the time constraints, but basically it gives us a magnification, access, different ways to approach the area of surgery that has actually given us a lot of hope that now we're making finally a change and hopefully it's going to be translating an impact of survival in the future.
Well, you mentioned minimally invasive. I think you're one of the leaders in that area of laparoscopic treatment of this, which is not to necessarily make a big incision, right, and to open the patient up. What is the advantage of doing a surgery like that laparoscopically?
It's the term minimally invasive means through small incisions you put some cannulas, then put some gas inside the abdomen and create room to be able to work. And then you can use a robot, and that's robotically assisted. You could do laparoscope, that's laparoscopic. Either of those treatments are very good. Depending the location of the tumor, the procedure is much more or less complex to do it through the minimally invasive approach. And also in terms of science, depending the location of the tumor, there's proof that laparoscopic is or minimally invasive is so much better. On the other ones, we're still studying it to see. Now the advantages again are for the patient, not just the typical things of a lesser incision, faster recovery, and a prompter return to the normal activities, and smaller incisions, but also the amount of blood that is lost during the procedure, and the meticulousness the more you can do the procedure.
And you're finding that these techniques are changing constantly?
Oh yes, absolutely. I mean, these are not things that can be learned from one moment to the next. The surgical community has taken this very seriously, and in fact we had world meeting of guidelines that 9 surgical societies, 21 countries here in Miami, that our institution was co-sponsoring, that we have been able to come up with guidelines that have been published on the best surgical journals.
Terrific. Now, interventional oncology, we're talking about, it's an offshoot of interventional radiology, is that correct?
Absolutely.
So
yes.
You're talking about ways to treat tumors inside the body without opening the body up.
Absolutely.
So tell me what kinds of interventional oncological treatments you can do for pancreatic cancer.
That's a great introduction to interventional oncology. So what we do is use imaging guidance, such as CAT scan, ultrasound, or X-ray fluoroscopy, which is live X-ray, to perform procedures. Earlier on, when our specialty was evolving, we were mostly involved in the diagnostic part. We would inject the dye, and this is before CAT scan, and we'd tell the surgeons, okay, we think there's cancer here. But now with cross-sectional imaging, such as ultrasound and CT and MRI, the need for diagnostic angiography is no longer there. And this slowly morphed into getting involved in treatments. Started out with vascular treatments, which is a big part of what is being done. And oncology was kind of a subspecialty that evolved over the last 2 decades. Started out in the early 70s with catheter-directed treatment of liver cancer in Japan, and then in Italy they performed the first alcohol-guided ablation of parathyroid tumor using ultrasound.
You're guiding
a needle or a catheter. When you use a catheter, you're going through the blood vessel to the tumors to the blood vessels that feed the tumor, and you're able to deliver the chemotherapy or selectively radiation directly to the tumor without affecting the surrounding normal tissue.
Interesting.
So the side effects are lower, the recovery time is faster, and almost all the procedures we do, the patient wakes up with a Band-Aid, and they typically go home the same day or the next morning. So with ablations is where we use a needle, and we place the needle directly into the tumor, and we use 3 different types of energies to kill the tumor. We can use heat, which is called radiofrequency ablation or microwave ablation, or we can freeze the tumor to -20, -30, which is called cryoablation. And the newest form of energy that we use is electricity, and this technology is called electroporation. And so this has been around for about 10 years now. So you have 3 different modalities where you actually place the needles in the tumor and you kill them by delivering these energies
Directly to the tumor.
directly to the tumor
Without opening the patient.
without
up.
opening the patient.
Well, I've been lucky enough to talk to Dr. Narayanan before and to see a procedure in person. And one of the devices that we have at Miami Cancer Institute is called the nanoknife. And I know you're a pioneer of this technology, especially when it comes to treating pancreatic cancer. We do have some footage of kind of, we can explain, you can
Sure.
explain a little bit about what's happening here with the nanoknife, which is that
Electrical energy.
electrical energy.
So microwave and cryo have been used in the past to treat cancers, even pancreatic cancer, in an operating room setting where these surgeons would open the abdomen, expose the tumor, and place the needles. What happened with the advent of this technology called the nanoknife, which uses electricity, we were able to place these needles without the need to open the patient, although it can be done that way also, precisely with imaging guidance. And so we use the CAT scan guidance, and we place these needles to bracket the tumor. And the unique part of this technology is the fact that it can be used in close proximity to blood vessels without hurting them. And so the first patient was treated back in 2010, and we published the first human experience and studies to follow that. And we're very excited now to bring the first randomized controlled trial to look at the impact of this technology in pancreatic cancer to the Miami Cancer Institute. And I'm honored to serve as the lead investigator for the study.
So you're seeing a lot of hope in this type of technology for this kind of treatment?
Absolutely. I think of what we've studied so far, we've known from our experience, what we call as a retrospective experience. What we're doing now is moving the science forward, putting it to the real test of having a true randomized control trial, which would give us the highest level of clinical evidence.
So we're talking about the clinical evidence, and doing the clinical trials and all of that is very scientific. But do you have any successful patient stories that you'd like to share with us, Dr. Asbun, of surgical patients or other patients that you've seen maybe beat the odds a little bit when it comes to pancreatic cancer?
Of course. I mean, we love what we do, but if we wouldn't have successful stories, probably we couldn't make it, especially for this time. I mean, we love our patients, we love what we do, but we want to make sure that we're making an impact. And yes, I can sit down and talk to you about many of my patients, even the ones that we were not being able to completely cure. We have patients, something comes to my mind, a lady was brilliant, that she lived 8.5 years. And in fact, towards the end, she was consoling me, saying, hey, I lived 8.5 years. I was not supposed to be here. And during that time, she had grandchildren. She became dean of a university. She remarried. Then that's what she was trying to remind me. And those are the people that keeps us going. Those are the ones that show us how to face adversity, and what are the things we can tell our next patient it's needed to be done.
I couldn't agree more, and I think that is one of the things that keeps us going, even in the face of a diagnosis like this, the ability to give hope. Me too, I have patient stories. One that readily comes to my mind is a professional golfer who was given 3 months to live, and was asked to get his things in order, and we're now 3.5 years out, and he's playing and currently disease-free at this point. So, I think pushing the envelope, thinking outside the box, working as a team. I feel cancer is a team sport, and when all of us get together and give our best, it shows in the outcomes.
Go ahead.
And that's a very important point, Carol.
Yeah.
I mean, you have mentioned several times that we're leaders in what we do, and that is true, but our patients humble us. The behavior on how they deal with adversity, as I was mentioning before, truly humble us. We learn from them.
And you're learning all the time. I know research is a very important aspect of Miami Cancer Institute. How do you feel about being able to take part in these kinds of research studies?
I think it's first of all, it's a great honor, and I think it's fantastic that we're not just offering just the clinical part of the treatment, but we're also advancing the science. And the one that I talked to, it's a pivotal trial, the first one in the United States, which is FDA approved. And to bring that sort of a trial to our institution, I think it's a great honor. And in the years to come, we'll definitely understand more and have more studies in this area.
I know, Dr. Asbun, I know you and I have talked before that Miami Cancer Institute, is fairly new, about 3 years old, but they went out and recruited, as you said, top experts from around the country and around the world. Give us a little bit of your background and why you were interested in coming here.
I was very fortunate. I worked at an institution before coming here that I'm very grateful, Mayo Clinic, which obviously has a tremendous reputation. I spent there over 10 years. When somebody came and started offering me a job to move out, I thought, no, probably not, until I learned more about what the goal is and what Miami Cancer Institute strategy was. Just circling back in research, because I could start telling you more things about Miami Cancer Institute, that can help us illustrate actually why people like Dr. Narayanan and myself are here, because since it is indeed a new institution, the support to do top-notch research is there. And we're able to bring projects like the one that Dr. Narayanan came, or the one that I brought in terms of the guidelines, in a way that it is really facilitated and expeditious. We're very well-established institutions that have many projects may not move as fast. Then maybe I shouldn't be telling you that little secret, but it's a reality. And we are bringing research fellows, clinical fellows at a speed that it will be very difficult to accomplish on a well-established institution.
And sorry to interrupt, I want to also flip the coin on that. Is that just that we've got a lot of researchers and doctors in ivory towers? You guys are also very involved in presenting information to the public through programs like this. And I know there's an upcoming panel or public meeting about pancreatic cancer. Can you tell us when that's going to happen?
The springtime.
Springtime,
in
okay.
the springtime we're going to do a community event that is going to be a true multi-specialty question and answer interactive. And we plan to have hopefully a good attendance from the community. It's going to be a opportunity for South Florida community to reach us directly and bring questions and interact with us through a significant period. It's not going to be a half an hour, it may be a half a day or maybe a full day, depending how we're going to finish the agenda. But it's coming towards the spring.
Well, we'll remind our viewers, and we'll probably do another program shortly before that to make sure everybody knows where they can come and talk directly to our experts about that. I'm sorry I interrupted you before.
No, what I was just going to add was, we just talked about the studies that we are involved in.
Right.
Our colleagues in medical oncology and radiation oncology also have cutting-edge trials that they are running at the Miami Cancer Institute. I just wanted that information to also be known.
Yes, and that is one area that we haven't necessarily delved into today, the radiation oncology, but as Dr. Asbun touched on, we have the full complement of all the radiation therapy technologies, including a machine called MR-Linac. And I don't know if you two would like to talk about any of the radiation technologies. It's not your area, but I know that we do have a great reputation for that.
Yeah, there's all types of radiation oncology approaches available at our institution. The MR-Linac that you have said, obviously we're not the experts. We have superb experts that are also leading those techniques worldwide. To my knowledge, and I may be wrong, but we were the first ones to have MR-Linac in our institution. And basically one of the problems, and I'm going to very simplify it.
Of course.
Hopefully our colleagues are not listening, but one of the problems with radiation is that the body is in constant motion, and the radiation has to be so precise that if you move a millimeter, then you are off target. With this machine, when the target moves, the machine stops applying the treatment. then when the target comes back into the planned area, the machines automatically activate. Then the dose that can be applied is much higher than regular because the surrounding tissues are not really affected as much.
So that's what we've been talking with all of your treatments, trying not to affect the surrounding areas, the blood vessels and the vital organs. I do believe we are getting some questions, so let's start with the first one. Does age play a factor on who gets pancreatic cancer?
Typically, it's not a disease that's diagnosed in a very young patient.
Okay.
Usually it's older patients, middle-aged and higher. But I wouldn't say age is actually a risk factor.
Okay. Okay. Would you like to add anything?
No, I mean, it is true that the majority of our patients are not extremely young. However, we do have patients that come at ages that we get surprised, and we have seen that more and more because unfortunately pancreatic cancers appears to be increasing in incidence.
And that is too bad, but we don't, like you said earlier, we don't want to scare people. We want to show you all the different ways that there is hope for fighting this disease, and that they are advancing all the time thanks to efforts of these doctors and researchers around the world. That's another question. When you do have surgery for pancreatic cancer, does the pancreas actually get removed?
Yes, absolutely. The portion of the pancreas gets removed.
Okay.
Rarely we take the whole pancreas out for pancreatic cancer. For other diseases, yes, but for pancreatic cancer, usually we take the portion of the pancreas where the cancer is, along with a margin, if you want to call it like that, of normal pancreatic tissue that is surrounding the cancer. In that way, you assure that the whole tumor has been taken out. Gotcha. And that is also done with neighboring lymph glands, through which the cancer may drain into.
And Dr. Narayanan, who is an ideal candidate for nanoknife? How is that determined?
So typically there are two types of patients that we use the nanoknife in. Those vast majority of them are not surgical candidates who cannot have surgery. And the second group of patients is those where we want to downstage them to surgery. I mean, they're not candidates now, but after this treatment, they become candidates for surgery. Okay. But that's a smaller percentage. The vast majority of them belong to the first group. The ideal patient for this treatment would be somebody who is still in good health, good performance status, somebody who does not have a history of irregular heartbeats or cardiac arrhythmias, because this technology uses electricity. It can predispose somebody to cardiac irregularities if they do have that history. And then tumor size. In our study that we published back in 2017, we looked at different factors, and we found that anybody with a tumor size less than 3 cm and under did better. And again, favorable ability to place these needles without causing collateral damage. That's something which over the years we've identified different techniques to overcome that limitation, but the first three would be the important ones.
And when you talk about downstaging, that is trying to shrink the tumor so it's more easily removed? Am I right?
That is correct.
Okay.
The goal again is to hopefully to bring these patients to surgery to take the tumor out.
All right. Well, we are coming to about the end of our time today. It went very, very quickly, and thank you for everything that you've told us today. But before we wrap up, I'd like to ask if each one of you have a final thought to leave with us. Dr. Asbun?
I think it's basically what we have discussed before. We need to demystify the bad reputation of pancreatic cancer. I'm not saying that we need to be in denial. Pancreatic cancer is an aggressive cancer, and yes, still one of the worst cancers in terms of survival. However, we're finally making changes. We're at crossroads, we're making an impact, and the worst thing is to just hear the term, I have a pancreatic mass or a pancreatic cancer, and think, oh my God, I'm gonna be dead tomorrow. Hope should be there all the time, and just make sure you have a good plan and you feel comfortable with the people that are treating you.
Terrific.
I think even with all that we offer and what we do, a patient's mindset plays a huge role in how they respond to the treatment and to the cancer. So I think when we offer them potential solutions, which may or may not be available in other places, you are providing them with something to look forward to and something that can improve their mindset and help them get better.
I think that's very true, very important. The mindset, the mind and body connection. We're learning more about it all the time. Thank you both so much. Great information today.
Thank you, Carol.
And thank you very much for watching today. I'd like to remind you to please follow us on our social media channels. They're going to be up on the screen in a moment. Our links for Facebook, Twitter, LinkedIn, and Instagram. And if you follow us, you'll get the latest health information and also updates on events that we sponsor here at Baptist Health South Florida and the next edition of Facebook Live, Resource Live. On behalf of everyone here at Baptist Health South Florida, I'm Carol Higgins, and thank you for watching and have a great day.